one of the reasons why I wanted to bring this up is it's something that commonly comes up, and it's a very common thing to see on ultrasound. And even if you're doing your point of care ultrasounds, I know that's big now for you guys and for a lot of people. Interestingly, a lot of OBs don't do bedside ultrasounds anymore, and the FPs are increasing the amount of bedside ultrasounds, POCUS. So it's kind of an interesting swing in dictum, where the OBs used to be the only ones doing bedside ultrasounds, and now it seems like FPs are, because the OBs don't want the liability in OBs. So it's just kind of a interesting transition from the OBs don't want to do them anymore because they don't want the liability, to the FPs are doing a lot of their own. This is something easy to diagnose, and it can have some significant bearing on where you might want to deliver a patient, or what you need to do. So remember, there's two ways to define polyhydramnios. The first way is the maximum vertical pocket of greater than 8 centimeters. So any maximum vertical pocket greater than 8 centimeters would make it polyhydramnios, or an AFI of greater than or equal to 24 centimeters. And that's pretty universal for all gestational ages. Unlike oligohydramnios, which is gestational age dependent, the polyhydramnios is pretty much universally across all gestational ages. The other thing I want you to think about is, if you have true polyhydramnios, I was told this once, which I think is a very good way to look at it, is you should be able to put a baby on top of the baby with fluid. So if you have the baby here, and the uterine wall should be way up here, so it should be enough room, you can almost put another baby on top of the baby. So there should be that much fluid if it's true polyhydramnios, because sometimes the measurements are kind of funny and it adds up to greater than 24, but when you look at it, you say, that really doesn't look like true polyhydramnios, because there's not that much room. But you still have to call it polyhydramnios, but that is not nearly as concerning as if the fluid is greater than 35 centimeters. Because once you get above 35 centimeters, which is severe, they recommend the baby actually be delivered at a tertiary care center. And I know we don't make that big of a deal here because we are a tertiary care center. But if you're in a rural hospital, or you're at Jay County still delivering, or Randolph County, if you get an AFI that's 35 or 40, you probably should send that out for at least a consult. And now the recommendation, and this is 2018 data, so pretty recent, says that you should deliver at a tertiary center, and we'll go over why. The grade is based on severity, so there's mild, severe, and then extreme. So it's mild polyhydramnios is 24 to or greater than 24. Severe is greater than 30, and extreme is greater than 35. The good news is, most of the time, 60 to 70% of the time, it's idiopathic, and there is no reason, if you will, for the polyhydramnios, and it does not have any bearing on the pregnancy outcomes. However, of the other 30 to 40%, there is a significant reason for that polyhydramnios, okay? This does occur in 1% of all pregnancies, so it's not like you won't see this relatively frequently. Now, when you look at the reasons for the etiologies of polyhydramnios, and these tables are directly out of that paper I sent you, then you first think about two issues. Either there's too much urine being produced, or the urine is not being reabsorbed or basically reabsorbed or reprocessed. So the reasons for impaired swallowing, there could be a GI obstruction, and then you look at duodenal atresia, TE fistula. So the duodenal atresia would be your double bubble, and that would be like Down syndrome. Your TE fistulas, those can be really hard to find, because most of the time the story is you don't have a stomach bubble present, but in a partial TE fistula, you can have a stomach present. And so you can basically miss those very easily, no matter who you are doing the scan. There could be a thoracic mass present, which is obstructing the esophagus. So especially in some of the CCAMs, if you have a large diaphragmatic hernia, that also makes sense. That diaphragmatic hernias would have increased fluid because of the twisting and contortion of the bowel. So those are some of the most common GI obstructions, and I've seen every one of these. So these are not uncommon. Neuromuscular, you can have myotonic dystrophy. Arthrogryposis, I think we underestimate how much arthrogryposis is present. It's still really rare, but I have seen 3 or 4 cases of those. If there's an intracranial anomaly, which leads to poor swallowing reflux, and especially in genetic disorders. So the neuromuscular a lot of times, and that's why when you get above 35, they get concerned about the genetics and other issues that would need a tertiary center. And then of the craniofacial abnormalities, if you have a cleft lip or palate, obviously cannot swallow effectively. If you have micrognathia, and we've had some families with Pierre Robin, so we've seen that not too uncommon. Or if you have like a big fetal goiter or a big fetal neck mass, then that can also lead to blockage of the esophagus. In the excess urine production, we see UPJ obstructions, which is your ureteropelvic junction obstruction, really commonly, especially in male babies. So a lot of those will be have increased fluid because of the contralateral kidney causing increased urine production. You see it in mesoblastic nephromas, and believe it or not, in Bartter syndrome and fetal Bartter syndrome because of the high output. Cardiac structural abnormalities, this is basically the amniotic fluid can actually be similar to like edema. So it can be a compartment of edema. So if you have a cardiac structural anomaly that's leading to high output failure, you can actually see polyhydramnios, which I think people underestimate that component. There's also tachyarrhythmias. So if a baby's in SVT, we can see polyhydramnios for the same reason. There can be a sacrococcygeal teratoma. The sacrococcygeal teratomas can get so large. We had one as large as a basketball. And because of the vascular load, it's basically causing a lot of the cardiac output to go to the sacrococcygeal teratoma, once again leading to heart failure, or the same way with the chorioangioma. So if you have a big tumor in the placenta that's very vascular, that's why placental tumors are really important, especially if they're vascular, to see how big they are, because they can also lead to cardiac failure and lead to polyhydramnios. So there's a lot of cardiac reasons that we see behind, and I've seen every one of these as well. And then obviously if mom has diabetes, then there's, if the baby has hydrops fetalis, and then like we said, the most common is idiopathic. Any questions on that? I mean, those are pretty straightforward why you get a consult. So as an FP, if you get back a ultrasound report, or if you're doing a bedside ultrasound for dating and you see all this fluid, that definitely should get a maternal fetal medicine consult, because we'll talk to them about doing genetics. And I'll be honest, we usually don't offer genetics unless it's above 35, but we've seen 2 or 3 that had AFIs above 40. And 2 of the 3 I did amnios on actually did have a abnormal CMA. So interestingly, but all 3 of them had normal chromosome karyotypes, but 2 of the 3 had abnormal CMAs, which I thought was pretty interesting. So anything above 40 probably should get chromosomes for sure. The following parameters should be assessed. What is the growth? What does the cardiac anatomy look like? So if necessary, to do an echo, especially if it's above 35 or 40. Placenta for presence of the chorioangiomas, like we talked about. See if there's fetal movement, because if it has like an arthrogryposis or some kind of neuromuscular disorder, a lot of times those babies aren't moving normally. Positioning of the fetal hands, once again, for arthrogryposis, you get some very odd angulation and posturing, especially in the hands. You can get club feet, obviously, but the hands are usually the telltale sign. The presence and size of the fetal stomach, once again, looking for TE fistulas or esophageal atresia, or if you have a double bubble, then you get your duodenal atresia. Positioning of the fetal neck, because when the babies have a big goiter, so in a mom who has hyperthyroidism, it's possible. One of the reasons why we look for a fetal goiter is twofold. One is if you have a big mass in the neck and the head is very deflexed, is that something you can deliver vaginally? Absolutely not, because of the cardinal movements. Remember, one of the cardinal movements, the head has to flex. If the head is deflexed and extended that much, then it will not come through the birth canal. And generally, you're going to wind up with a face presentation and mentum posterior, which is non-deliverable. So we always look at the neck and look for the head position, the spine, to make sure we have a nice curvature of the spine, that we don't have a big deflection of the head and a big mass sitting in there. So that's really important, not only for diagnosing the polyhydramnios, but for diagnosing a non-deliverable presentation. The fetal kidneys, you always want to look at to make sure that the kidneys aren't dilated. If you see bilateral pyelectasis, even mild, remember that is a soft marker for Down syndrome. So, and the duodenal atresia is a soft marker for Down syndrome. So here you go again. So if you get polyhydramnios with a duodenal atresia or with the renal pyelectasis, especially bilaterally, then you should be thinking about chromosome analysis, especially for Down syndrome. And then the lower spine and pelvis for evidence of a sacrococcygeal teratoma. Although the classic sacrococcygeal teratoma is type 3, remember type 1 and type 2 can be all internal. So sometimes we find these big internal masses that are actually attached to the inside of the spine, and they're all intra-abdominal, but they can get very large, and they can be very vascular, and they can cause significant amount of trauma, or not trauma, but problems at delivery. And it can even lead to an abdominal dystocia. So we've had babies before where they deliver, shoulders deliver no problem, and then you have an abdominal dystocia. And talk about a very anxiety-provoking experience. When I was in Detroit, one of my friends, Mike Leonardi, was on call as a fellow one of his first nights, and they deliver this baby, comes all the way down to the umbilicus, and then it just hit a rock, and they were unable to deliver it. So they get a bedside ultrasound. They actually intubated the baby, crazy case, because they intubated the baby on the perineum because they couldn't get the baby out. And the baby was trying to breathe, and of course then the cord stops pulsating. So they actually intubated and were ventilating the baby on the perineum while they were trying to figure out why the baby wouldn't come out. And they actually found a 20-centimeter sacrococcygeal teratoma. She had gotten all of her ultrasounds, well, all of her one ultrasound for her screening anatomy at the medical center. So back then we used to save VHS tapes and pictures because we didn't have all the packs and stuff we do now. So they actually pulled the VHS tape and the still pictures from that study, because we're like, how do we miss a 20-centimeter mass in our hospital? And so they went back, and by goodness, there was absolutely nothing on that kid's spine at 20 weeks. So it goes to show you how fast these can grow, because she was now 36 or 38 weeks. She was term, but not post-term. And that thing went from not even being visible at 20 weeks to she had a 20-centimeter mass by 36, 38 weeks. So it was pretty impressive. So just a case in point, because of course we thought we missed it. We thought we did a terrible job. And then lo and behold, it wasn't actually there at the screening anatomy. So the outcomes of the polyhydramnios is based on the severity. And once again, 24 to 30 is mild. That accounts for up to 70% of the cases. And the risk of a fetal abnormality is only 6 to 10%. And it's risk of a neonatal abnormality when it's born, actually on the outside, is 1%. And that includes your genetics. Now, when you get to moderate, obviously it goes up, and it accounts the deepest maximum vertical pocket. And I've not seen people use that criteria, the MVP, for the severity, but there it is in case you go somewhere where it does use the maximum vertical pocket. Part of the problem you get into is once you get a maximum vertical pocket over 16 millimeters, you can measure fluid anywhere. It's very difficult to tell where your 4 quadrants end to begin because there's just fluid everywhere. So it's probably not a bad system, because once you're above 16 centimeters, that's a pretty significant fluid pocket. So the moderate, 20% of the total, but it does account for 10 to 15% of the fetal abnormalities and 2% risk of having a neonatal abnormality. Now, once you get to the severe, and this is what we're mostly concerned about, it's less than 15% of the total, but it accounts for up to 40% of the risk of, so that baby has up to a 40% chance of a fetal abnormality. So at minimum, you should have a level 3 ultrasound performed when the AFI is greater than 35. And even more importantly, that baby has a 10% chance of having a significant abnormality at birth. So that's a pretty high number. So the basic end of summary is, what are the recommendations from the paper? Well, if we suggest that polyhydramnios is present by this measurement, and it's weak recommendation with low quality evidence, which is interesting. We recommend that amnio reduction be considered only for severe maternal discomfort, shortness of breath, or both in the setting of severe polyhydramnios. And that's a strong recommendation with low quality of evidence. And the bad news is the fluid will reaccumulate and be back to that level usually within 1 week and sometimes within 48 hours. So the problem with doing amnio reductions for maternal comfort is I prepare them that they may have to get it every week until they deliver, which never gives them much great encouragement. The other thing that's interesting is because the uterus is so big that they may go into preterm labor, but it also may be very difficult to get them into labor because of the Starling's curve. The babies have the uterus stretched out so much that it's kind of like a twin pregnancy, why it's so hard to get them into labor, because the uterus doesn't want to contract well because of the Starling curve. So, you know, you got to keep that in mind. We get these massively dilated uteruses, you want to decompress them when you can. And clearly that raises an issue because I know Dan likes to use a pedental needle and other people like to use whatever, a spiral electrode to put a little hole in it. But I'll be honest, in my experience, anytime I try to do the needle or I try to do a spiral electrode, 9 out of 10 times the sucker ruptures on me anyway and winds up just being a tidal wave regardless. So make sure you have some blankets down. We recommend that indomethacin should not be used for the sole purpose of decreasing amniotic fluid. There was some studies in massive polyhydramnios putting people on indomethacin because we know what it does to the amniotic fluid, on the thought that you use the side effect as the treatment. However, the problem is it also closes the ductus prematurely. So you got to be careful using that, and probably should only be used at medical centers where we can do MCA, or not MCA, basically PDA Dopplers every day on the baby to make sure that the PDA is not closing, which is not easy to do. So most of us will not use it. They recommend fetal surveillance is not required for the sole indication of mild polyhydramnios. So what do they mean by that? Well, because the risk of stillbirth is low, the risk of placental insufficiency is low. In the past, we used to do NSTs on all of these. I think a lot of us are still interested in using NSTs simply because we want to see if they're contracting or not, but that's not a good indication for quote unquote antenatal testing, just to see if they're contracting or not. So basically, once again, weak recommendation with low quality evidence. Really nice. Now, the next recommendation is we recommend that the labor should be allowed to occur spontaneously at term. And there's no reason to induce them less than 39 weeks. And if you do want to induce them, we got to find a reason, and maternal discomfort is not one of them. If you can prove somebody is hypoxic, like their pulse ox is below, and you don't have to be below 90, but below 95% because of the dyspnea and because of the mass effect, then that could be an indication for a 38-week delivery, but there's clearly no indication for a preterm delivery in these patients. So that's number 5. And number 6 is we recommend women that have a severe polyhydramnios deliver, once again, at a tertiary center because of the significant risk of fetal anomalies and neonatal abnormalities. So, and that is it. Kind of a short presentation today, but fortunately, because we got a little late start, but, you know, I think it's something that you guys will certainly see in your practice for sure, and nothing that I think is too mundane. The other thing I thought that, you know, if you guys are interested is we've been seeing an awful lot of microcephaly, not microcephaly to the level of the Zika virus, but definitely having a lot of babies less than the 10th percentile right now. And whether it's COVID virus related or not, nobody knows. But there is a specific workup you should do for microcephaly that's persistent as well. And I thought that might be a good topic for next month. And I honestly planned on using something else with today's topic, but because of the schedule, it wasn't going to happen. So sorry, it's a little brief. I can give you some time back today, which is unusual for me because I know most of the time I keep you 20 minutes over. So there you go. I'm going to give you some time back, but I'll open up the floor for any questions that you guys may have. I think this one's pretty straightforward, but I think it was interesting because really, I don't think many people are aware of the severity that they need to transfer those patients with that high of an AFI to a tertiary center. I don't think that was something that was clear when I was a resident, but then again, I've always been skewed because I've always been at the tertiary center. So Luke or Mel or Justin, I appreciate you guys being on. Does that make sense to teach our residents moving forward? Jen, I see you. Do you guys have, and Jennifer Wilson, both Jens, do you guys have any questions or comments on that? Go ahead, Luke.
Yeah, hey, Dr. Landwehr, thank you. I have kind of a two-part question. Really, I've got three questions, but the first two-part question is when we are ordering the CMA and chromosomes,
yes.
Could you maybe just briefly tell us exactly the process for ordering that? Does it need to be on the cord blood? Can it be?
Yeah, okay, that's a good question because there's
afterwards. And then sort of the second part of that question is you mentioned some of the CMA analyses are coming back abnormal, but the chromosomes are normal. So it's just micro deletions or weird little
or phase shift, abnormalities. They're off one base pair, and then remember everything after that base pair gets shifted. But because of the way our proteins are coded, then everything on the rest of that arm of the chromosome pretty much gets trashed. So it's important. I thought everybody knew how to draw blood off the cord for chromosomes, and they don't. You don't draw it off the cord segment that you're using for your blood gases. There's not that much blood in there. So you're not supposed to get it from the cord segment that you're given to the nurses for the cord gases. That's what attempted the first time we did this. I told them to get chromosomes. One of the Boston Center doctors was on, and they tried to draw from the cord, and they were like, well, I couldn't get anything but like 1 cc from the cord, and they said we needed 10 cc's, and I'm like, ah! So what you do is after you get your cord segment, it's kind of like collecting cord blood for the donor cord blood. Mm-hmm. So, but you have the nurse to give you a 20 cc syringe with whatever size harpoon needle you want. I usually use an 18 gauge and go into the umbilical vein. So you clamp off your segment, pass that off to the nurses. If you want gases, it's always important to get that first, right, for the cord gas in case you need it. And then when you have the cord still clamped, you just stick the umbilical vein. You can wipe it off with alcohol if you want, that's fine. But it's not really, we're not too worried about having infectious contamination, but you do want to not have any maternal blood contamination on it. How do you know? You don't. So you wipe it off and just make sure there's not blood dripping off of the cord when you draw it. As long as there's not blood around it, just stick the umbilical vein and draw off 20 cc's. They want it in a purple top EDTA tube. The nurses know this now. And you can call me 24 hours a day. Dr. Ely and them would call me after hours in the middle of the night, but I'd rather be called and give them the right blood. They want it in an EDTA tube, which is the bigger purple top tubes. Don't give them the little dinky one. Give them the big regular like you draw for mom. And that's what they really need. That's it. Now, the other thing I've been sending them, because it was the way I was trained in case they want to do other cultures, and sometimes it works better, is I use a plain green heparinized tube, which is the same size. It's like 5 to 10 mLs. And it's got heparin in it, but no additives. So you don't want the liquid in it. The EDTA tube has liquid in it. The heparinized tube will say heparinized, and it's a green top tube, not a green tiger top, because you don't want a serum separator. You want just a plain green top tube, and the nurses know that. Then the third thing you do is, and this is important too, because you can get maternal cell contamination. They are supposed to draw blood from the mom, and we always forget. And then we have the mom come back to the lab, and they send a purple top tube from the mom, and they use that as a control to make sure that when you drew cord blood, you didn't get any maternal cell contamination. So they do a comparison test to make sure it's really, especially now, obviously, if the baby's a boy, you don't necessarily have to have the maternal cell contamination, but I still send it because there's other kind of probes they do. But in a girl, for sure, a female baby, you definitely have to send maternal cell contamination studies, because they don't know, because the test is so sensitive that you might have a mosaic. Well, and if you have a mosaic, you want to make sure it's a true mosaic and not a contamination of maternal normal cells with the baby. So for example, a Down syndrome mosaic is a lot different than just a Down syndrome baby. So you want to make sure you got the correct diagnoses. And then you basically order it in the computer under cytogenetics orders, and it would be peripheral blood, and it says cord blood. So you order, and then on a case like this, you got to be careful. There's a couple different orders, but it's pretty easy. You order the you order the chromosome analysis with concurrent CMA, not reflex CMA. Because with reflex CMA, you can, but I get them concurrent. That way they're running them together. What the reflex CMA is if the chromosomes look normal, then they'll do the CMA. But then it takes a lot longer. And in a case like this, you just want to run them both together, so concurrent. So you can either do a reflex, and now obviously if it comes out trisomy 18 or trisomy 21, they'll just stop the CMA and they won't continue it. So to me, it's kind of like, even if you're doing them concurrent, a lot of times, if they find an abnormality in the chromosomes, they just won't run the CMA. So that's the second. And then what's the second part?
Oh, I think just the second part, you had mentioned that a lot of the chromosomes were normal on the babies with poly, but
correct. So
I think you already answered that.
So it's just a CMA, and most of them I've seen is microdeletions or syndromes where there's not even a microdeletion, but they find like a variant, like cystic fibrosis. They find a gene variant. I mean, it's pretty impressive what they can find on the CMA now. I'll be honest, it's pretty frightening, actually.
Yeah,
we got another baby that was born just a couple weeks ago that we did chromosomes on because of poly, and the CMA was abnormal. And the reason that was important is the CMA has actually shown that the baby inherited a gene that can be significant learning disabilities and have significant developmental delays. And interestingly, the dad carries the same gene. But the good news is, I guess there was variable penetrance. So he seems a little slow, but not to the degree the severe forms show. So in this, whatever genetic variant it was, since it has variable penetrance, the dad is relatively normal, not brilliant, but not severely handicapped like the baby could be. The bad news is they don't know how severe the baby is going to be affected until the baby gets older, which is really hard. So those are ones I send to Riley for counseling because I feel that's over my scope of counseling. So when I found this abnormality, the first thing I did is got a hold of genetic counseling and said, she's coming to you because this I have no idea. And then your next question.
Oh yeah, thank you for answering. And then really the third question was just kind of curiosity, and maybe other people were wondering, but that resident you were telling us about, the friend that, how did that baby end up getting delivered?
Well, they wound up having to do a C-section and bring it back up through the abdomen. So they had to replace the whole body, which he said was the hardest thing he's ever done, 100 times worse than doing a vaginal breech because the arms are out. If the baby's stuck to the head, in theory, with the Zalvinelli maneuver, you just tuck the head and push it back in, which I've never done, by the way. But in theory, you reduce the shoulder, you retuck the head, you flex the head and push it back in. And that's the Zalvinelli maneuver. The problem is when you got a baby all the way out to the umbilicus.
Yeah, you got to get the shoulders back through.
So I think what they wound up doing is a breech extraction and delivering the baby. I think that's how it went. He just did basically a reverse breech extraction and then delivered the nuchal arms backwards through the vagina. I mean, how crazy is that case?
With the baby intubated?
Yeah, then they pulled the tube as they were delivering it and then re-intubated after delivery. And you know what was amazing? That kid did unbelievably well. And they actually took the tumor off in the delivery room. The neurosurgeons came over because when they heard what was going on, they were so fascinated. And we were like at Riley and Methodist. So Detroit Medical Center is separate from Children's Hospital of Michigan. So the neurosurgeons literally came over to our hospital. So by the time we got the C-section done and got the baby out, they actually removed the sacrococcygeal teratoma in the delivery room.
Wow.
It was unbelievable. And the kid was left with like a little 2-centimeter scar. That was it. Because it was pedunculated. That's what they wanted to see. So it was like a pedunculated tumor. And that kid, when you saw it 6 weeks postpartum, had a little dinky scar on its sacrum, and that was it. 100% normal. It was the craziest ass case I've ever seen. I mean, it was insane. I mean, it was like 20 centimeters. I mean, this thing was mammoth. I mean, when they showed the tumor, it was just like mind-boggling. All right. Any other questions? Great questions, Luke. Any other questions?